Hi, my name is Darren Abbas. I'm a postdoc in Dr. Wan's lab, and today I'll be discussing how fat grafting alters fibroblast subpopulation expression to reduce radiation-induced fibrosis. So radiation-induced fibrosis is a well-known sequela of radiation therapy. This clinical phenomenon has been tolerated since the inception of radiation therapy, giving a significant improvement in the morbidity and mortality outcomes of oncologic diseases. However, the basic processes underlying these clinical changes is not well understood at this time. With this study, we aim to better understand the cellular and molecular processes driving radiation-induced fibrosis and fat grafting's ability to reverse these changes in irradiated tissue. To do this, we irradiated the dorsal skin of 30 adult black 6 or wild-type mice. We then harvested this tissue at week 0, 2, 4, and 8 following radiation therapy to study how the sequence of healing after radiation occurs. We found that the sequence from acute at week 0 to subacute at week 2 to early chronic at week 4 and to late chronic at week 8 caused a progressive increase in dermal thickness, collagen density, and linear organization of the collagen fibers. Utilizing a machine learning algorithm, we analyzed over 294 features of the Picker series red images, and we noticed that the collagen fibers in the acute phase still had some overlap with the control or non-irradiated skin. But by weeks 2 and 4, all that overlap in collagen architecture is lost. And then by week 8, we likely see some remodeling starting to occur, as this group had no architectural features similar to any of the other irradiated groups or the control group. To look at radiation's effect on vascularity, we utilized an endothelial marker in CD31 and saw a similar progressive worsening of vascularity following radiation wounding. We then looked at several fibroblast subpopulations with CD26, DELC1, and SCA1 markers and discovered that the expression of these subpopulations shifted between these three clusters throughout our timeline. CD26, a marker of engrailed that has been previously studied in our laboratory regarding dorsal fibrosis, became the predominant subpopulation by week 8 after radiation wounding. We then utilized a rainbow transgenic mouse model and irradiated these mice to see how the cell lines and fibroblast subpopulations within the irradiated tissue expanded over time. And with our rainbow model, we stochastically assign one of 4 colors to a specific cell lineage, and we notice a clonal expansion of these fibroblast subpopulations that survive radiation wounding at week 4, with significant pooling of the individual colors within the dermis. We then needed to determine whether the main cells driving these phases of fibrosis were systemic or local in nature. To do this, we performed a parabiosis procedure with wild-type mice and transgenic constitutive GFP-expressing mice, and then irradiated both of their dorsa with the same radiation regimen as before. Using FACS analysis, we demonstrated adequate blood chimerism at 2 weeks following the procedure, with expansion of the GFP-positive blood cells from 0.4% to 12.5% of the wild-type mice. Following radiation of the dorsum, the irradiated GFP mice skin had greater than 44% of GFP-positive cells, while the irradiated wild-type mice skin only had 3.73% of GFP-positive cells. And 3.7% of that 3.73% of GFP positive cells were also found to be CD45 positive, which signified that almost all the GFP positive cells within the irradiated wild type mouse skin were of hematopoietic origin, and shows that the cells driving these fibrotic changes were tissue resident fibroblasts versus systemic cells. Once we established these changes that occurred at a cellular level after radiation, we wanted to see if fat grafting could rescue these effects. We irradiated wild-type mice and grafted their dorsa with healthy human fat samples at week 4 and allowed the grafts to stay until week 8 before harvesting. We found that fat grafting was able to rescue all the changes in dermal thickness, collagen density, collagen architecture, and vascularity. Now that we know what the fibrotic changes are and that fat grafting can reverse these changes, the next step was to figure out exactly how these processes occur. Using single-cell RNA sequencing, we analyzed our irradiated skin samples and found 5 distinct fibroblast subpopulations via GO pathway analysis: immunomodulatory, an ECM, a mechanofibrotic, a regulatory, and a support fibroblast subpopulation. We also discovered that throughout the timeline of radiation wounding, there was a progressive expansion of the ECM and regulatory clusters and a regression of the immunomodulatory cluster. When we did single-cell RNA sequencing of our fat grafted samples, we noticed the same 5 fibroblast subpopulations were present, but that fat grafting was able to prevent the expansion of the ECM and regulatory clusters and maintain the immunomodulatory clusters more closely to non-irradiated tissue ratios. So to summarize, with this study, we were able to define the sequence of radiation fibrosis at a cellular level from acute to chronic. We identified the 5 fibroblast subpopulations propelling these changes and how those fibroblast subpopulations change over time. And we displayed fat grafting's ability to alter these subpopulations, specifically the immunomodulatory, the ECM, and the regulatory fibroblasts, to rescue the fibrosis following radiation exposure. For future directions, we have identified a potentially novel fibrotic pathway within the RNA sequencing data of our ECM fibroblasts, and I started to test this hypothesis with in vitro and in vivo experiments to determine if cell-based therapies could alter these fibrotic pathways similar to fat grafting. I would like to thank Dr. Wan and Dr. Longacre and all the members of the Hague Lab for the help with this project, and I'll take any questions you have at this time.